Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thank you for that kind introduction. So there's a lot to get through, and I usually only have like 10 or 15 slides max, but I have more than my usual, just because I wanted to get through this update, but I want to be mindful of the cases. And I'm just going to go over a few of these and just hit the bullet point highlights of some of the changes in the OI guidelines over the last couple of months. There's been a few changes that do affect clinical practice. So we'll get through them. Start with toxo. So the main things are that we shouldn't be doing baseline screening on everyone who comes in with HIV, unless their CD4 counts are less than 200. And then the other major thing was that trimethoprim sulfamethoxazole was added as a preferred regimen for people with acute infection with toxo. So what does this mean in terms of limiting baseline, and why was this done? So the recommendations currently are that individuals with CD4 counts less than 200, not everybody with HIV, should have some preventative measures to prevent exposure. And that's, not eating raw meat or undercooked meat, washing hands frequently, and avoiding changing cat litter. And if that is not avoidable, wearing gloves and washing hands if you do. This is only for people with CD4 counts less than 200. And the reason is that seroprevalence is pretty variable, from really high in some areas of the world, and in the US it's about 11%. But clinical disease is extremely rare in people with CD4 counts less than 200, and the majority of people who get symptomatic CNS toxo are going to be people with very advanced HIV and CD4 counts less than 50. So really trying to minimize the work and the messaging that we do for people who have CD4 counts greater than 200. I think the bigger change was that toxo preferred regimen now includes trimethoprim sulfamethoxazole. As you know, we have had pyrimethamine with sulfadiazine as the go-to for treatment of CNS toxo, but there have been a number of challenges with obtaining it, both financially and just availability. And we've had increasing data clinically to support the use of trimethoprim sulfa, which I think many people have already been doing for years. And so that's now an A2 recommendation. And you'll note that it is a lower dose than what we use for PJP, which is the 15 mg per kg, and here it's 5 mg per kg. And that can be IV or PO twice daily. And that note about if pyrimethamine unavailable, that's why we would use that. And I think realistically, it's mostly unavailable for most patients. And so here, pyrimethamine, we know has excellent brain penetration, so that's why it remains an A1 recommendation. We have a lot more experience with it, but the experience with trimethoprim sulfa is growing. And because of the shenanigans from pharmaceutical companies about cost with this is essentially unavailable. There was a paper in CID that came out just last year that looked at real-world experience with trimethoprim sulfa as an alternative agent to pyrimethamine for toxoplasmosis. And you'll find here in this nice figure from that study that the clinical response was essentially the same, radiological response, and mortality was lower, and discontinuation of therapy was lower. So and this was a meta-analysis of a number of studies, and based on this, that is why the recommendation this year has changed to include trimethoprim sulfa. All right, moving on to pneumocystis. I think what's changed is that there's simplified indications for starting primary prophylaxis, and then intravenous pentamidine was added as an alternative for prophylaxis. So what are the simplified indications? So in the past, we've always thought of 200 as our cutoff for PJP prophylaxis. Here is a little bit clearer language in taking into account the data that has been available for a long time, that incident PJP in patients who are between 100 and 200 CD4 counts and have suppressed viral loads is really, really uncommon. And so this language has changed to basically put this up front. If your viral load is detectable and your CD4 count is between 100 and 200, that is an indication. And then if you're less than 200, regardless of a viral load, then that's an indication. So this means that for our patients who have been persistently suppressed but never have had a really good CD4 count rise, then we don't need to obligate PJP prophylaxis indefinitely. That there are good data to support discontinuation and not being at risk for PJP. So the other new thing is intravenous pentamidine. And you can see here on the list of alternatives. So the preferred therapy is Bactrim, 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 as you can see. But there are a number of alternative therapies that you can use if people are seronegative for toxo. And one of them is aerosolized pentamidine, which is felt to be equivalent to dapsone and atovaquone in terms of efficacy. However, there is some cross-reactivity with dapsone and if allergy to trimethoprim sulfa, or if someone has G6PD deficiency. So we have used aerosolized pentamidine. As we all know with COVID, that was really challenging to have a negative pressure room and be able to give a nebulized treatment. Intravenous pentamidine was added here as a once monthly, so for people who may not be able to adhere to a daily oral regimen, then you can use IV pentamidine. And really, the data for it is from people without HIV, actually. It's very limited in people with HIV, but it has been studied in other immunocompromised patients, and you don't need the negative pressure room. Pyrimethamine as an alternative is pretty expensive, we know, and limited availability, and atovaquone, the bioavailability varies, and a lot of people don't like it. So this could be another option for patients who need PJP prophylaxis, but can't do the other or won't do the other treatments. I personally have not used it yet, but it may be an option for some of our low barrier patients who may have challenges with adherence and multiple pill burden. Candidiasis, I know this is probably not that exciting to most people, but there are two new agents that were FDA approved for vulvovaginal candidiasis, ibrexafungerp and oteseconazole. Sorry, I can't even pronounce that one. And really, there are no data in people with HIV. And more interesting question is, can we extrapolate to other uses like esophageal or oropharyngeal? There's no recommendations now, however, because these are relatively new. And we only have data that led to FDA approval for vulvovaginal candidiasis. So ibrexafungerp, which is a funny name, it is a oral beta-glucan synthase inhibitor that was FDA approved about 3 years ago and looking at clinical trials that for uncomplicated vulvovaginal candidiasis. So it is an option. It's a 1 day, 2 times dosed medication. We don't have it on formulary within UW Medicine, but it is being reviewed, given that it is one of the options that is available for patients now, and it is one of the recommended therapies. Oteseconazole is a new tetraazole antifungal that was also FDA approved a couple of years ago, and for recurrent vulvovaginal candidiasis. So the recommendation here is not for uncomplicated vulvovaginal candidiasis. This is for patients who have had severe or recurrent, and you dose it sort of interestingly, day 1, day 2 as a loading dose, and then weekly dosing for 11 weeks. It's months of therapy, and it's also not studied in people with reproductive potential, so not in pregnancy, no data, so we do not recommend it for women who may get pregnant. Like I said, I think the more interesting thing is if this would be an option in the future for patients with candidiasis elsewhere. Okay, switching gears to bacterial enteric infections. So some changes here just in the last couple months to address the increasing antimicrobial resistance among bacterial enteric pathogens, and then some updated recommended regimens for empiric therapy that I'll go through. We have definitely seen more antimicrobial resistance amongst our Shigella isolates here, and that has led to some changes in our empiric therapy, even in people without HIV. In general, antimicrobial prophylaxis to prevent bacterial illness is not recommended, including for travelers. So we don't give prophylaxis, but you can give early preemptive therapy to abort symptoms or decrease symptom duration for patients. And so it's more of like an on-demand dosing for people who have symptoms of travelers-related diarrhea. And that's same here for people with HIV. We don't do primary prophylaxis. And I'll show some data, but there's a high rates of antimicrobial resistance outside the US to fluoroquinolones, and that is usually not the recommended therapy when we're talking about early treatment or empiric treatment in general because of the increasing rates. But I'll show you some newer data that may lead to some changes in that because it's such a dynamic field. This is for updated recommendations for empiric treatment of bacterial enteric infections. And I'll talk about Shigella separately. For people who have high CD4 counts without the systemic symptoms, we treat them like they are essentially don't have HIV. We just treat them like an immunocompetent person. For people with lower CD4 counts and more severe diarrhea, you can give azithromycin or ciprofloxacin as options. And then for people with HIV and severe disease and low CD4 counts, a lot more symptomatic, you can do hospitalization and further diagnostic evaluation and then ceftriaxone. So for our inpatients, ceftriaxone is really what we've been using. And then I'll talk a little bit about the Shigella in particular and empiric carbapenem. So this alert came out earlier this year of suspected extensively drug-resistant shigellosis in King County. We had a similar bullet announcement that came out the year before, and we've had clusters of cases periodically throughout the last several years. And this one, it was a cluster of 4 cases. And so really considering Shigella in patients experiencing homeless in particular, international travelers, people living with HIV and MSM in particular. So many of our patients in our clinic, we would be concerned about drug-resistant Shigella. So this is interesting data from NARMS, which is the National Antimicrobial Resistance Monitoring System. And this shows Shigella from 2023 and now 2024. And so this is brand new data that we see that actually the Cipro susceptibility went up in the US at least. And so this is US data compared to last year where we were seeing a lot more resistance that led to clinical practice change where we weren't using fluoroquinolone therapy. As I say, this is so dynamic, and using your local antibiogram, if you have one in your area, to help guide therapy is helpful because we do see swings to azithromycin isolates being predominantly resistant to now being much more susceptible again. And so again, if someone is really sick though with Shigella, the guidance is to use a carbapenem upfront. And so these are people that are requiring admission in general, severely ill, very symptomatic, particularly patients with low CD4 counts. While you're awaiting the susceptibility data, which can take a while, most of us have moved to molecular diagnostics like the enteric pathogens panel or BioFire panel that gives us an answer within 2 hours, but the susceptibility takes longer. And in the meantime, if you've got somebody really sick, you want to make sure you have something effective on board. And then here are some other alternative therapies. As I said, that the Cipro is still here if it's susceptible. Our data show in our area that it is more susceptible again, and then you've got some alternative therapies here. Duration of therapy is generally 5 to 7 days, and then Cipro 5 to 10 days, and then azithro 5 days. And it may be reasonable for patients who are more severely immunocompromised with poor clinical response to extend those antibiotics. And obviously, if anyone's bacteremic, you would treat for longer. And if they have recurrent infections and they're very immunocompromised, then you can treat for up to 6 weeks. There is no prophylaxis recommended after that, though. Lastly, this actually update came out earlier this year, but I heard from Hillary that this question recently came up. So I just wanted to clarify the updated language for MAC prophylaxis. Essentially, it's more clearly worded in that primary prophylaxis is not recommended for adults who immediately initiate ART. We're deprioritizing MAC prophylaxis in favor of just getting their immune system up. However, if patients are not on ART or remain viremic or have challenges with adherence and getting suppressed, then it may be reasonable if their CD4 counts are really low to start prophylaxis. And as we've discussed in ECHO before, in these patients with really low CD4 counts who are not on ART, maybe for a really long time, you really want to do a good clinical assessment, assessing for any symptoms of disseminated MAC, and obtain a blood culture for MAC if there's any concern at all, so that you're not partially treating the MAC with prophylaxis. Okay, lastly, there's some updates coming very soon because they're in final editorial review. Histo, crypto, cocci, and community-acquired pneumonia should be coming out in the next couple of months. And here are my take-home points. Trimethoprim sulfa is now one of the preferred regimens for toxo. IV pentamidine was added as an alternative for PJP prophylaxis. There's 2 new antifungals that I can barely pronounce. And then empiric carbapenem is now recommended for severe Shigella infections while awaiting susceptibilities, and MAC prophylaxis, primary prophylaxis, is not really important anymore for most people. Thank you so much.
Thank you for watching this edition of the Mountain West AETC Project ECHO Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.